Hello, my name is Mason Conley, and today I'm going to be doing the EKG workshop. I have been an ICU nurse for the past 2 years. I have some of my certifications, my CCRN, my ACLS, and my PALS, as well as my BLS. So EKGs have been my friend for the past 2 years. So my overall goal with this presentation is I'm basically combining all the things that I had when I was in nursing school and wish I would have known or used the methodology to study all in this presentation. That being said, there's going to be a lot of information in this PowerPoint. I could probably even go more in depth. I tried my best to just do the high points because at the end of the day, you as nursing students, I want you to be able to interpret your own rhythms and know when it's time to take action. So let's get started. So let's start with the basics. What is an EKG? An EKG is a non-invasive diagnostic tool used to monitor and track the heart's electrical activity. Here in this diagram, you're able to see the different sectors of the EKG, your P wave, PR, QRS, ST, your T wave, and your U wave. So more specifically, when are we going to use an EKG? So in a clinical setting, so like a cardiologist's office, they're probably sent there for that reason. They're going to have an order for it. But mostly what I'm going to be talking about is going to be centered in a hospital setting. I personally will give a lot of my information based from an ICU experience, while it is still important to understand all of this on a med-surg step down, PACU, whatever you decide you want to go into when you graduate. So most of the time when you have an EKG, you're going to have an order for it. But in my experience, there have been moments where, I was stuck on night shift, there wasn't a doctor readily available, and I was able to use an EKG to determine, is this something I need to move up? Is this something that I need to raise concerns to the provider? Because in all honesty, when you're a brand new nurse, you're working night shift and it's 2 o'clock in the morning, it can be scary to want to reach out to a doctor and call them about something if in the back of your mind, you're not sure if it's a big deal or not. So you can use an EKG to diagnose irregular rhythms, determine blocked or narrowed arteries, determining maybe if there was a previous MI. You also can evaluate treatments, drugs included. So if you're going to be administering cardiac drugs, this is a good tool to be able to see, are those drugs doing what you want them to do? Also, if a patient has a pacemaker, is the pacemaker capturing? Is the pacemaker doing its job? If a patient is having frequent heart palpitations, chest pain, shortness of breath, and finally, change in patient condition. That goes back to what I was saying earlier. If you have a patient and you just have a gut feeling something is not right, you're able to use this to kind of pinpoint what's going wrong and to validate your feelings. So here is a little video on the pathophysiology about it. Like I said, this could go into a lot more depth. I could do an entire lecture just on the pathophysiology alone. That being said, I'm just wanting you to be able to visualize what the EKG is doing, what the EKG is looking at. And this will give you a good visual, hopefully to have you put two and two together to be able to make the connection of essentially why are you doing this. So let's go ahead and start the video.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection. like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To understand the basics, let's start with an example of how we can look at the heart with only one pair of electrodes, a positive one and a negative one. Remember that at rest, cells are negatively charged relative to the slightly positive outside environment. And when they depolarize, the cells become positively charged, leaving a slightly negative charge in the outside environment. So let's say that when this set of cells is at rest, they're red. And then they turn green as the wave of depolarization moves through them. Now, if we freeze this wave of depolarization as it's moving through the cells, half of the cells are positive or depolarized, and half are negative or resting. And so there's a difference of charge across this set of cells. You can think of the charge difference as being a dipole, because there are two electric poles. And we can draw this dipole out as an arrow or vector pointing towards the positive charge. And remember, the electrodes detect charge on the outside of the cell. So this points toward where the positive charge is outside the cell. Now, if there's a dipole vector pointing toward the positive electrode, then the ECG tracing shows it as a positive deflection. The bigger the dipole, the bigger the deflection. If we unpause this, then everything becomes depolarized. And since there's no difference in charge now, there's no dipole, and so there's no deflection. Moments later, a wave of repolarization goes through. Pausing halfway through again, now the vector dipole goes in the opposite direction and faces the negative electrode, which means there'll be a negative deflection on the ECG tracing. Again, the bigger the dipole, the bigger the negative deflection. Now, even though it'd be nice if the depolarization wave lined up perfectly with the electrodes, usually that's not the case. So what we end up looking at is the vector component that's parallel to the electrode. For example, let's say the depolarization happened this way, at an angle. Then we'd break the vector into two parts, one going parallel with the electrodes and one going perpendicular. The one we care about is the one that's going toward the positive electrode, which causes the deflection. Though since this arrow is shorter, it's going to cause a slightly smaller deflection than previously. In other words, the size of the deflection on the ECG tracing always corresponds to the magnitude or size of the dipole in the direction of the electrode. The perpendicular component isn't pointing at the electrode, so it doesn't cause any deflection. In fact, if there's a depolarization wave that goes straight up, which is perpendicular to the positive and negative electrodes, then there'd be no deflection at all. In a standard ECG, there are 10 electrodes, 4 limb electrodes, one on the left arm, left leg, and right leg, and 6 precordial electrodes, V1 through V6, that wrap around the chest. And the right leg electrode is usually used as a neutral lead. Now, the heart's a 3-dimensional organ, right? So V1 through V6 line up in the transverse or horizontal plane of the heart. And each electrode is set up to detect any wave of positive charge coming toward them, which based on what we know already means that they're positive. These are collectively called the chest leads. Meanwhile, in the coronal plane, the non-neutral leads are called augmented vector right, or AVR, on the right arm, and augmented vector left, or AVL, on the left arm, both of which are represented as vectors that are 30 degrees up from the horizontal line. Finally, there's the augmented vector foot, or AVF, on the left foot, which anatomically isn't straight down, but it's close enough that it ends up representing the vector facing straight down on the diagram. Just like the precordial electrodes, AVR, AVL, and AVF each detect any positive deflection coming toward them. Now, in addition to these 3 limb leads, there are also bipolar limb leads called lead 1, 2, and 3, which are recorded using 2 electrodes instead of just 1. Lead 1 uses the right arm as the negative pole and the left arm as the positive pole, forming a vector that goes to the right. Lead 2 uses the right arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 60 degree mark. And lead 3 uses the left arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 120 degree mark. So in total, you've got 6 leads from the limb leads and 6 from the chest leads, leading to a grand total of 12, which gives you your 12 lead ECG. Now, the point of having all these leads is to get different views of the heart, making it easier to see exactly how that wave of depolarization moves through the heart. As an example, consider how the 6 chest leads, V1 through V6, register the depolarization waveform called the QRS complex. The exact same depolarization wave might appear mostly negative in V1 and V2. It might be isoelectric in V3, and mostly positive in V4, V5, and V6, all because of the exact direction and magnitude of the vectors at different points in time. Similarly, each of the limb leads produces its own viewpoint of the depolarization wave as well. Now, all the limb leads and chest leads can be grouped based on the regions of the heart that they're nearest. Problems in specific leads or groups of leads suggest that there might be a specific region of the heart that might be affected by a disease. Leads 2, 3, and AVF are inferior leads because they're near the inferior wall of the heart, which receives blood from the right coronary artery. Leads 1 and AVL, along with 2 of the chest leads, V5 and V6, are all considered lateral leads because they're near the lateral wall of the heart, which receives blood from the left circumflex artery. Finally, V1 and V2 are considered septal leads because they're nearest to the interventricular septum, and V3 and V4 are anterior leads because they're nearest the anterior wall of the heart. Both of the septal and anterior regions are served by the left anterior descending artery. All right, as a quick recap, in a standard ECG, there are 10 electrodes, 4 limb electrodes and 6 precordial electrodes that wrap around the chest. These electrodes are used to make 12 leads, each of which illustrates the movement of positive charge on the outside of heart cells. The ECG tracing shows a depolarization wave moving towards an electrode as a positive deflection, and one moving away as a negative deflection, each of which is proportional to the size of the dipole. The point of being able to get different views of the heart is that it makes it easier to see how the wave of depolarization moves, which provides valuable information about the heart's structure and function. Thanks for watching this video on the basics of ECG.
Okay. Like I said, there is a whole lot of information in there, and all I needed that for was for you to be able to visualize what's going on in the heart when you're looking at an EKG. I really like how he uses the imagery to be able to show you where the different vessels are and how they correlate with each lead. But I'm not going to sit here and have you memorize the angles and the dipoles and all of that. I just needed you to make that correlation between lead placement and what part of the heart it's looking at. Okay, not needing to watch it again. Okay, so just reiterating, where the P wave is, it's representing atrial depolarization. It's essentially saying what that squeeze is doing in the atrium before it moves on to the ventricles. And notice how the P wave has a much smaller inflection than the QRS complex. And if you look at it from this perspective, it makes sense because the atriums are not having to squeeze as hard as the ventricles are. Meaning when an atrium squeezes, it's sending blood into the ventricles. It doesn't have as much distance to go. Therefore, it doesn't need as much power to overcome resistance to enter into the ventricle. Now, the ventricles are responsible for pushing majority of the blood outward into the body. So that's going to face a much higher point of resistance than the atrium. So therefore, it's going to have to squeeze harder. That's why your depolarization in the QRS complex is much taller than your P wave. And then in the diagram on the right, you're able to see the different nodes. Your electricity is going to begin in your sinoatrial node. From there, it's going to go in a systemic motion through your AV node, all the way into your bundles of His. And in this next video, it's real short. It's just to give you an image of where the electricity is going, how it's supposed to flow. When we get into rhythms that are having blocks or problems with these nodes, it's because they're either starting from a different node than they're supposed to, there's a block in the communication of the electricity, and it's no longer systemic. It's no longer in a good relationship with each other. So let's look at this.
Your heart's electrical system includes three important structures: the SA node, the AV node, and the His-Purkinje system. They trigger and carry electrical signals through your heart to make it contract and relax. The SA node is a bundle of special cells in your upper right atrium. These cells create the electrical signals that trigger your heartbeat. The SA node is sometimes called your heart's natural pacemaker. Electrical signals triggered by the SA node travel through the atria to the AV node. The AV node is a bundle of special cells between your heart's upper and lower chambers. The AV node can be thought of as an electrical bridge. It allows electrical signals to travel from the atria to the ventricles. The His-Purkinje system is in your heart's ventricles. Electricity travels through the His-Purkinje system to make your ventricles contract.
Okay, on to the next slide.
Your heart's
Okay, now let's get into it. How are we going to apply this? So you will follow the fifth intercostal space, which is basically going to be near the armpit, and that's where V5 is going to go. But that's in a perfect world. Sometimes we have patients who anatomically are not like this diagram, like they might be significantly larger. And when we have our simulation, we will go over what's an easier way to find this area to put your V5, but you're going to have a lead on each extremity. You then, for your chest leads, one's going to go on the right side of your sternum, and it's going to go in a systemic pattern all the way down to their armpit, almost going towards their back. Make sure that the areas are clean and dry and minimal hair. It may be beneficial if you have a really hairy patient to go ahead and shave it down. The reason being is because if there's not a good connection between your leads and the skin, example, if there's sweat, water, hair, you're not going to get an accurate representation of what's going on, or it might just not pick anything up at all. This is just referring back to the first video that we watched. All I'm really trying to emphasize here is every lead is giving you a different image of the heart. It's giving you a different plane. And this is important because if we're going to use the example of occlusion, like a myocardial infarction, your first leads, V1 through V4, may look completely normal, but it may show up only in V5 and V6. So it's important to know that this is displaying different areas of the heart, and that's going to determine treatment. It's going to determine, what disease process is going on. Okay, the right-sided EKG. It's really not as common. When it's used to evaluate an RV infarct or an inferior myocardial infarction. I've also seen it used, well, it's not necessarily a right-sided EKG, but when I started working in COVID and patients were prone and we needed an EKG, risk versus benefit, it wasn't beneficial to flip our patients back over just to do this procedure. You are able to do a posterior EKG as well if the situation calls for it. Now into the interpreting. So step one, no matter where you are, ICU, clinic, you're going to assess your patient. Is their skin dry or are they sweaty? Are they experiencing chest pain? Are they short of breath? This is because that's the first step in determining, what am I going to see on this EKG? If your patient is ANO times 4 and everything's normal, more than likely, they're not going to have anything extremely significant on their EKG. But if you had a patient who is diaphoretic and short of breath and is having chest pain, you can create a mental image of what your EKG is going to look like. So there's no surprises. So once you visually assess your patient, you're going to move to step 2, what is the rate of your rhythm? Is it within that 60 to 100 beats per minute, which is normal? Less would be bradycardic, more would be tachycardic. Step 3, is there a P wave for every QRS complex? And do your QRS complex look normal? So you will go through the rate, then you're going to go and look in front of every one of your QRS complexes and say, is there a P wave present? And then are your QRS complexes wide? Are they narrow? That's going to establish whether or not they look normal. Step 4, are they equal distance apart? Are they regular? if you take a tool and you go from point to point on each QRS, do they have the same little amount of little squares in between each one? And same for your P waves as well. Step 5 is the P wave length normal, which is 0.06 to 0.12 seconds. Step 6 is your PR interval normal, which is going to be 0.012 to 0.2 seconds. So let's test drive trying to figure out the rate of some rhythms. So here you're going to see a 10-second strip, and I know it's a 10-second strip because you can see small boxes inside a bunch of much larger boxes. Now, right here, where you see these large boxes right here, you are going to need 30 large boxes to equal 10 seconds. And the reason you want 10 seconds is because whatever you multiply by 10 is going to equal a 60-second strip. For example, in this strip right here, we have 1, 2, 3, 4, 5, 6, 7 QRS complexes. Your rate is going to be 70 beats per minute because there are 7 complexes in a 10-second strip. Each small square is equal to 0.04 seconds. And that's important to know because when we're starting to measure our PR intervals, et cetera, we are going to use those small boxes to measure to see if they're within range. For example, okay, what's the rate of this rhythm? So we have 3 QRS complexes, so that rate is 30 beats per minute. Now for this one, we have 1, 2, 3, 4, 5, 6, 7, 8 QRS complexes. So that's going to be 80 beats per minute, which is within normal range. And here, this is going to be 17 complexes, therefore 170 beats per minute, which is very, very fast. And there are your answers. So when we're talking about regular versus irregular, it can get a little confusing because when we're referencing regular or irregular, we're really discussing, are the R to R intervals, P to P intervals the same? If they're equal distance apart. P waves are present, PR intervals within desired range, and our QRSs are equal distance apart. That's what's going to make a regular rhythm. Now, irregular. Some vocabulary here is arrhythmia/dysrhythmia. They're interchangeable. And it's a condition which the heart beats at an irregular manner. There may be no P waves, and charges are beginning in the incorrect node. That's not the sinoatrial node. Your QRS complex are not going to be equal distance apart. This is a good example would be AFib, which we'll go over here shortly. So here's the gold standard of rhythms. This is your normal sinus rhythm. And the reason it's sinus is because when you have a P wave, that means it's beginning from the sinoatrial node. That's where we wanted to start. It's also the gold standard of a rhythm because our PR intervals within desired range, if you were to measure from QRS to QRS, those are going to be equal distance apart. And that's how I would love every patient to look like, but unfortunately that's not the case. And our rate is going to be 60 to 100 beats per minute. Sinus bradycardia. This is whenever we have something, it very much looks like the strip I had you look at earlier, but it's below that desired rhythm. It's below 60 beats per minute. We still have a P wave for every QRS. Every QRS interval is equal distance apart, but this would not be considered a quote unquote normal rhythm. So signs, symptoms, and treatments. First of all, before you go doing anything crazy to treat a patient with sinus bradycardia, you need to determine, are they symptomatic or not? Is this their baseline? Occasionally, or actually very frequently, athletes are going to have a bradycardic rhythm. It's normal. Younger people may occasionally have a bradycardic rhythm, and that's okay, and no further treatment would need to happen. But symptomatic people, they're experiencing the signs that their body isn't pumping enough blood and oxygen to their vital organs. I mean, when you think about it, if your blood is taking too long to get to vital organs like the brain, that's why you're going to experience confusion. They're not getting the oxygen they need to their brain. They're going to get short of breath. They're going to be tired. They could be confused. And treatment depends also on the cause of the bradycardia. If it's an electrolyte abnormality, you're gonna fix the electrolyte problem. If it's an infection, you're gonna treat that infection. Medications, for example, beta blockers or calcium channel blockers, can affect how fast your heart is beating. So if you go into a patient room and you're scanning your morning medications, there more times than none will be a warning or be a set of instructions on that order that say, hold this medication if heart rate is less than 55 and notify provider. Because you don't want to go in there and your patient has a heart rate of 50 and you're about to give them some metoprolol or some labetalol. You could make it go way, way down. In emergency situations, atropine is going to be given. Typically, I've only seen that when we're in a code blue situation, and that's just to jumpstart the heart and get it beating as fast at a faster rate. And then pacemakers, that's going to be a permanent resolution to be able to get the heart to beat at the appropriate times per minute. All right, sinus tachycardia. Again, we're having our P waves, our QRS complexes are normal distance apart. It can mirror almost a normal sinus rhythm, but that rate is above 100 beats per minute. Emphasis, the P waves are still present. We'll have another rhythm come up next where it looks like sinus tachycardia, but our P waves are not present. And our QRS is still equal distance apart. Going back to what we said, bradycardia, if we're going to treat this, are they symptomatic? Is this their baseline? Sinus tachycardia is a normal mechanism our body uses, especially in fight or flight. If we exert ourselves, if we're anxious, if we have too much caffeine. And it doesn't become an issue until when someone is at rest and it's still tachycardic. Some symptoms that patients could feel are heart palpitations, chest pain, dizziness, fainting, and shortness of breath. Because when you're thinking of what's happening in tachycardia, the blood in the ventricles and the atrium, it's not having enough time to fill before it's being shot out into the body. So you're still not getting the necessary oxygen you need if you're beating too fast, because you're not able to get that full volume into the ventricle and back into the body. Some causes can include fever, medications, dehydration, anemia, bleeding, and thyroid. With fever, if you treat the fever, treat the infection, it can resolve the tachycardia. Dehydration, you're going to replace fluids. Treatments for this are going to include beta blockers, calcium channel blockers, and a catheter ablation is when a physician goes in and essentially burns the overactive area that could be overstimulating the heart. Here we go with supraventricular tachycardia, SVT. It's an extremely fast atrial rhythm, and the QRS complexes are going to be narrow. The impulse originates from the bundle branches above the ventricles, so they're not beginning in the sinoatrial node, so it's not considered a sinus rhythm. Rate normally above 160, but it can happen below. It's just if that P wave disappears, then you have a problem. It's going to be, this is more severe or worse than sinus tachycardia. Symptoms are going to be very similar to the tachycardia slide. Serious cases can lead to cardiac arrest. So some things you can do to help go back into a normal rhythm is vagling, laying down, ice on the face, and coughing. So if you have a grown patient, you could tell them to bear down, blow through a straw. But think about your pediatric patients. They're not going to know what you are talking about if you say, hey, vagal down like you're going to the bathroom. That's why it's good to use the straw and tell them to blow out super hard, put ice on their face, or tell them to cough. But if that doesn't work, then we're going to have to move on. Adenosine, which can be kind of a scary medication to give. A physician needs to be at bedside when it happens because it stops the heart for a few seconds. It has a very short half-life. So when you're administering this drug, you're going to lift the extremity, have a stopcock, and slam that medicine in, and then slam a flush in right behind it, because you don't want that half-life to give up before it makes it to the heart. Catheter ablations to ablate the overactive electrical areas. beta blockers, calcium channel blockers, my bad, digoxin, and potassium channel blockers, or synchronized cardioversion. And when you have a ZOL, there is an option when you're cardioverting, which is different than defibrillating. You will have it sync up to the heart rhythm so it doesn't shock at the wrong point of the strip, so you don't put them in a lethal rhythm. So the difference between cardioversion and defibrillation, they're not interchangeable. Defibrillation, you're giving a much powerful shock to the heart to correct its rhythm, and it's one time. So if you have someone in VFib or VTAC, and you hear, on TV shows where they're saying, defib 150 joules, they're just giving that one shock one time to try and get it to reset. Cardioversion is using quick, low energy shocks to restore the rhythm. So it's going to happen multiple times at a much lower level. If your patient isn't awake, you're able to go straight into cardioverting. It is an option on the ZOL as well as the defibrillator. But if you have an alert patient that needs cardioversion, if it's not emergent, it would be in the patient's best interest if you recommend to the physician some sort of sedation, because it does hurt and it's scary. Okay, my not so favorite part, the heart blocks. So when you look at this rhythm, it looks like normal sinus. You might be quick to be like, oh, it's fine, it's a normal sinus. But if you look closer, this is where it's important to have a systematic regimen of how you evaluate your strips, because if you look at the PR interval, it's greater than 0.2 seconds. And this is due to the delay in transmission from the atria to the ventricles. That electrical message is being stalled from the atria to the ventricles. So it's considered a block because it's not getting there as quick as it needs to. It's mostly asymptomatic. It occurs commonly in teenagers, athletes, and young adults with an overactive vagus nerve. No treatments, but needs to be monitored because it can progress into some of the other blocks. So there's two types of second degree. This is type 1, a Winky block. So it progressively lengthens the PR interval until a QRS drops. The phrase that always helped me in school was longer, drop, you have a Winky block. So when we're looking at this, we have a P wave, QRS, but you see the distance here is much shorter than the distance here. So you have a P wave, a QRS, but when you get to this P wave, the QRS disappears. And it's happening rhythmically. So it's the same thing here. So for every third QRS or a third P wave, the QRS disappears. Symptoms can include chest pain, fatigue, nausea, dizziness, and shortness of breath. Treatment is determined whether or not a patient is symptomatic. If symptomatic, we're going to go with a pacemaker. Second degree type 2. It's intermittent drops in QRS that's not related to a type 1. So here, even if you're measuring your PR intervals, there's no elongation that's leading to the drop. It is just happening spontaneously, so here we can see for every 1, 2, 3 complex, we're on the fourth one, we are dropping that QRS, and it's not related to the lengthening of the PR interval. You need to evaluate this one. It's more serious than the type 1 because it could lead to a complete third degree heart block. Signs, symptoms, and treatments are the exact same as the type 1. Treatment will depend if it's symptomatic, but more than likely you're going to end up with a pacemaker and frequent visits to your cardiologist. So here is the third degree. Yikes. So P and QRS have no relationship or communication. The heart is just doing whatever it wants and firing in all directions. P to P intervals are equal distance, but the QRS complexes are random. So your heart is not moving in that rhythmic motion with the electricity from the different nodes like I showed you earlier in that video. This can lead to cardiac arrest. Most of the time when people are discovering this rhythm, it's in an emergency situation. You're going to have chest pain, fatigue, fainting. It's the most serious. It could lead to cardiac arrest, and they're going to end up with a pacemaker. So With paced rhythms, I, again, could have a whole lecture just on the different settings and the failure to capture and the different types of devices and what they do. But for time's sake and for this lecture, I just want you to be able to identify it on the strip. So here you can see it's being paced because it has the pacing spikes. That's what the arrows are pointing at. So all I need you to do is to be able to recognize these pacer spikes so you know that person has a pacemaker. Now, capturing is the spike. When you hear the term capturing, it's talking about the charge that's being administered from the pacemaker. Failure to capture is when the heart doesn't respond to the pacemaker's charge. For example, if I were to see one of these pacing spikes, but it didn't follow with these lines right here, it was still just straight, that would mean it was failure to capture. The heart is not responding to the pacemaker's charge. So here is a rhythm called atrial fibrillation, better known as AFib. And this is where the measuring from point to point on the QRS complex is going to be really important because, as you can see, without even really having to measure, they are not equal distance apart. And you can't even tell if there's a P wave or a QRS because it's got that fibbing or wiggly lines in between the QRS complexes. And what's happening is the heart is literally quivering. That's why we're seeing these lines right here. The rate is going to be less than 100 in this case. Otherwise, we would be getting into the territory of AFib, RVR, rapid ventricular. So let's go on to the next one. Signs, symptoms, and treatments. Symptoms include fatigue, heart palpitations, trouble breathing, and dizziness. Some of the biggest risk factors are going to be high blood pressure, CAD, and obesity. A huge thing to know about AFib, if it is untreated, it will lead to a stroke. And that is because when your heart is quivering, sometimes blood gets left behind in these chambers and they can coagulate and throw a clot out into the body. So when we have someone who has chronic AFib, we're going to have something for rate control. That's going to be digoxin, metoprolol, and ditalazine. Rhythm control medications, example, amiodarone, and blood thinners to reduce that risk of blood clots. So we're addressing trying to keep it under a normal rate, trying to convert it back to a normal rhythm, and try and prevent this patient from having a stroke, which is with warfarin or aspirin. And if you have a patient on warfarin, it takes a little while for it to start taking effect. And there will be some specific education you would have to give the patients on warfarin because they're at higher risk of bleeding. A flutter. So it's a supraventricular arrhythmia that's characterized by that sawtooth appearance. So if you had a test and it said, identify this rhythm, what is differentiating this rhythm from just regular AFib is this sawtooth appearance. It's mostly asymptomatic, but if they do have symptoms, it will be identical to AFib. Medications include antiarrhythmic, beta blockers, and channel blockers, very similar treatment to AFib. Further treatment that's more invasive is going to be cardioversion, ablation, or pacemakers. Rate control is important because a fast heart rate over long periods of time can weaken the heart muscles. Like I said earlier, imagine if you got on a treadmill and put it at 15 miles per hour and had to go full speed ahead for hours. Your muscles are going to get tired. Your heart is a muscle. It is going to get tired if it is overworked. So here we are with AFib, RVR, rapid ventricular response. AFib with a rate over 100 beats per minute. If sustained, it's going to need immediate intervention. In the ICU, if we have a patient with AFib RVR that's non-responsive to IV pushes or other treatments, they're going to end up on an amiodarone drip. So symptoms can be chest pain, dizziness, faintness. You're going to have some fluttering in your chest. Treatments are going to address the rate. So you're going to have some metoprolol or propranolol. A cardizam drip or an amiodarone drip may be started, and you could eventually end up having to be cardioverted. Okay. The asystole. It's a flat line. Nothing's going on. Cannot defibrillate this rhythm. There are rhythms that you can shock and cannot shock. So anytime you watch Grey's Anatomy and it says to shock, and this is what it looks like on the monitor, they're lying. your patient's not doing so good if this is their rhythm. Treatment is CPR, supplemental oxygen, epi, and if you're continuing several rounds of CPR and they are not responding, you're going to reference back to what an ACLS calls the H's and T's. Some of these include hypoxia, hypoglycemia, hypovolemia, tamponade, toxins. Maybe they have a clot. Their symptoms, well, outside of the picture, they're going to be non-responsive. They're not going to have a pulse, just completely non-neuro intact. If they continue, they're essentially dead. Pulseless electrical activity. There is not an image for this because it can be any organized rhythm or any evidence of electrical activity on the monitor, but they don't have a pulse. So a rhythm in a patient who is unresponsive and lacks a palpable pulse. And it's not a specific recognized rhythm. This is why I always tell my students, look at your patient and not just the monitor. It's very hard when you just want to rely on your technology. But if you don't go feel that pulse, they could be dead and you're not treating them because you're looking at the monitor. Okay, STEMI and an NSTEMI. So here on this strip, you can see that the ST is elevated above the QRS. That is a STEMI. ST segment elevated myocardial infarction. It shows up on an EKG strip and it's very easy to identify. Now, a non-STEMI, a non-ST segment elevation myocardial infarction may have ST inversion, but it also may not show up at all on the monitor, but a patient is still actively having a heart attack. How we're going to identify if someone's having an NSTEMI, we're going to assess them because they're going to have the same symptoms as a STEMI patient. And then we're going to do labs like troponins and do the trend of troponins to see if they're having a heart attack. Signs, symptoms, and treatments of this, they're very similar in symptoms. They're going to have chest pain, sweating, shortness of breath, anxiety, jaw pain, indigestion, nausea, and vomiting. Keep in mind, men and women present differently when they have an MI. Men are going to have that stereotypical grabbing of the chest, shortness of breath, and sweating. But women may come in and say, you know, I've had a lot of indigestion this week and my jaw kind of hurts. And they're not that stereotypical image of our heart attack patient. So it's important to know that because we don't want to write off someone's symptoms and miss this kind of diagnosis. Like I said, NSTEMIs can be diagnosed with rising troponin levels. Treatments are going to be, the gold standard is percutaneous coronary intervention, a PCI. As soon as someone comes in, we want to get them on the table and get that catheter in and open that artery. Another thing you can remember is MONA, which is morphine, oxygen, nitrates, and anticoagulants. And then lastly, beta blockers. Here is we're getting into our little more of a severe rhythm. This is ventricular tachycardia. It's monomorphic, meaning all of these little marks here look the same. They're an equal distance apart. They're wide QRS complexes, no P waves. The heart rate's usually over 100. Really not good. If they're responsive, this is responsive to fibrillation. But when dealing with ventricular tachycardia, we need to know if they have pulse or no pulse. Sometimes they can be responsive and alert, so you're not going to want to defibrillate an awake and alert patient. We may be able to treat it differently, but typically if someone goes into this rhythm, they're not going to continue to be responsive for much longer. Symptoms are chest pain, lack of responsiveness, shortness of breath. So further on in the treatments, that you're going to give them some supplemental oxygen, CPR, epi, amiodarone, or lidocaine, and defibrillation. VFib, characterized by chaotic wave pattern and no pulse, more disorganized than VTAC, even worse, responsive to electrical defibrillation as well. Everything else, this is the same as VTAC. Sorry. For SODs, day points. This is a specific type of VTAC or fast heart rhythm that starts in the ventricles. It's most easily identified by this ribbon-shaped or streamer-shaped pattern. See how it gets wider and smaller. Treatments include magnesium, potassium, and beta blockers. And this is because typically this is caused by an electrolyte abnormality, specifically magnesium. So we're going to replace that magnesium in order to get them out of this rhythm. Okay. So in the midst of all this information, where do we fit into this? What am I wanting you to grasp from this lecture? I want you to feel comfortable with being able to assess a patient and check their status. If you feel like something is wrong and you have that gut feeling, an EKG is a good tool to validate your concerns. Be able to recognize abnormal rhythms to take action. You may not be able to remember, oh, is that a type 1 or a type 3 heart block? But you know, if you see that in a type 3 that it's not communicating well, you need to call somebody. I just want you to be able to know when you need to start taking action and be able to track changes in a patient cardiac status. This is a funny you can click in your own time. I'll put it in the link below the video. If you would like some further practice, this is an awesome website that has a game for you to practice different strips. There is a couple rhythms on there that we did not cover, but there is an explanation on the Learn tab. And this is something that really helped me during nursing school. So let's do a case study. You are a nurse on a cardiac step-down floor coming in to get report. Your patient is a 59-year-old male with history of hyperlipidemia, asthma, obstructive sleep apnea, diabetes, and coronary artery disease. Yesterday, he went for a PCI for a myocardial infarction. He is ANO ×4 on room air. Patient uses the bedside commode. He has a left groin insertion site with tegaderm that is dry and intact. Blood pressure is 130/80 with a heart rate of 88, and temp is normothermic. He complains of pain at a 3 out of 10 and has a slight pressure in his chest. His bed rest order ended 2 hours before your shift began. You assess your patient and give him his 8 a.m. meds with pain medicine for his discomfort. At 10:30, the patient pushes the call light. You find the patient is diaphoretic with 8 out of 10 pain in his chest and shortness of breath. Heart rate is 110, BP is 170/90, and O2 is 89% on room air. What are your next steps? What are your concerns? So first things first, you would not leave your patient, you would call for help in this instance. A major concern with someone who had a PCI is reocclusion of that artery. So he's showing symptoms that he's having reocclusion by having another MI. So we would address our ABCs, airway, breathing, circulation. We would sit our patient up. We would put a nasal cannula on him. We would see what meds we have available. So if we have morphine, digoxin, and all of that stuff to help stabilize him, we're going to do that. And we're going to call our physician. More than likely, he is going to have you get an EKG. So you're going to do all the things that we described earlier, put on your leads, hook it up to the monitor. So now we're going to say that we got an EKG, physician is at bedside, you've given meds to help with the discomfort, patient reports relief of symptoms. But then we'll go to the next slide once we look at this a little more. So we can see that he's having ST elevation in these leads. So he is having a reocclusion. So the doctor is more than likely going to want to get him back to the cath lab, do another PCI. But then once his symptoms are relief and we're getting ready to go to the cath lab, his rhythm looks like this and he is unresponsive. What are we going to do next? Well, we are going to hit the code blue button because the patient is unresponsive with VTAC. We are going to start compressions. So in another module, we'll discuss a code blue situation, but essentially this patient is going to be code blue. They're going to be defibrillated. They're going to probably receive amiodarone, epi, the works. And if he doesn't respond to this treatment, it'll lead to intubation. So thank you for coming to my lecture. I hope it was helpful. If you have any questions, leave them in the comments. Until next time.